So let me welcome you all to this 80th edition of Thursday Musings. Today's topic is interplay of stress, resilience, and psychopathology. Before we proceed further, Tufan sir, if you allow, we can have a 2-minute silence for our senior psychiatrist, departed soul, Dr. Paresh Lakdawala.
Yes. Yes, let us have 2 minutes silence. After 2 minutes, we'll proceed on with the formal proceedings. Please observe 2 minutes silence.
Thank you, everyone. Can we proceed now, sir?
Yes.
Next slide, please. So let me hand over this session to the chairman of the program, Professor Dr. Tufan Pati. Sir is from Cuttack. He's very well known. I'm just handing over the session to you.
Yeah, skip over the formal introduction.
Sir, over to you.
Thank you, Alim. And I welcome everyone to the 80th edition of Thursday Musings, 20 sort of 100th edition. And we have got with us two vibrant and quite well-known, quite amicable young leaders of IPS, Dr. Alim Siddiqui and Dr. Amrit Patjoshi as our moderators. Both are professors of psychiatry. And I take the privilege to directly go for the introduction of the honored chairpersons. Next, please. Dr. Amrit Bodani is a private consultant in psychiatry from 1982 till today. He is a retired honorary psychiatrist. He was in the capacity of honorary psychiatrist from 1983 to 2008, 25 long years, in LG General Hospital, Ahmedabad. He is past president of Indian Psychiatric Society, GSP branch. His area of interest includes psychopharmacology and molecular biology of brain, quite befitting the topic of today evening. Welcome, Dr. Amrit Bodani. And then we have with us Dr. Mahesh Gowda. He is DPM Psychiatry in DNB. His present affiliation is Managing Director, Department of Psychiatry, Spandan Healthcare, Bangalore. Coordinates the DNB program of Spandana Nursing Home. Significantly has been instrumental in the successful launch and smooth running of the much needed rehabilitation services. His area of research interest include general adult psychiatry, rehab and re-addiction. Special interest, Dr. Gowda has made note of the contribution towards organizing conferences and various research and academic activities. Major awards and achievements, DLN Murthy Rao Award for Best Outgoing Student at the National Institute of Mental Health and Neurosciences, Neuroscience. Dr. Gowda is keenly involved in community activities and has made several media appearances on TV channels, participating in panel discussions and public awareness programs on mental health. His research and publications, Dr. Mahesh has published various articles in peer-reviewed national and international journals. Welcome, Dr. Mahesh Gowda. Welcome, Dr. Amrit Bodani. From this moment onwards, the proceedings of this evening are yours. Please proceed.
Good evening, everybody. Has Dr. Bhaskar joined?
I guess so, Bhaskar Mukherjee. Yeah. Please make Bhaskar as co-host. Bhaskar, unmute yourself.
Yes, I have joined.
Yeah.
Welcome, Bhaskar.
Just let me see why the video is not playing. It should not be like this. Yeah. Now everything is sorted.
Thank you. Chairpersons, you may proceed now.
Dr. Amrit sir, for introduction of Dr. Bhaskar.
Dr. Bodani, please introduce Dr. Bhaskar.
I'm not able
No
to see
need.
myself. Okay, I'll start. Good evening, friends. It's my pleasure to chair today's session. Thanks to Alim Bhai, Ofan Patti and Amrit Bhai for inviting me. I am assigned the job of introducing Bhaskar. The very easy job and the very difficult at the same time. Easy because last Thursday, Dr. Bijal had already introduced him and very lucidly told his details about his creativity, his intelligence, his passion, and all the things. So today I take this opportunity to say something about Bhaskar, which I perceive in him and my relationship with him. So today's description will not be about his academics or about his performance, but what I perceive him as a person, as a psychiatrist, as a scientist, as a human being. I know Bhaskar since 4 years through live CME. My staying with him at various places during his visit to Gujarat, during national conferences, and my personal discussion with him on WhatsApp, most of the time discussing various cases, my personal problem, my own COVID suffering, and he helped me a lot during that period. He gave me courage as well as guidance that how should I proceed. So this was the encounter which I cannot forget. Few days back, someone in the live CME said Bhaskar as a big fish, and instantly one word came to my mind, that was whale shark, and I wrote down that also. Why whale shark? Because whale shark is supposed to be a giant, silent giant, a gentle giant of the sea. And I perceive Bhaskar as one of the person who is giant as far as psychiatry is concerned, and is gentle also. But as happens, he is ruthless also on many aspects as far as destroying the old psychology, psychosocial sciences, and humanities, and all yoga and meditation and all these things which we have been, or many are being advocating since 2 centuries. So he has been ruthless in that, and maybe he has invited a lot of dislikes from many stalwarts, many seniors, and many so-called politically correct people. So this, but he doesn't care about it. He's that way bold enough, courageous enough to proceed on his path of searching psychiatry through brain. And this is a beautiful thing which I always appreciate. There was some Bhaskar, 50% Bhaskar in me, which is now awakened by him himself. So I think now I also feel somewhere that I have become half of the Bhaskar. Of course, not of his level. About 3 years back, during Lucknow conference, I told him he's a genius, which he disliked very badly. Since then, I have been feeling that I should replace that word genius because he doesn't like it with the word brilliance. So I think he is the brilliant person who can see psychiatry through brain, through genes, through molecular biology, and through from microscope to macroscopic view of psychiatry. And he calls the psychiatry is my baby, as if he loves him like a child. So he doesn't allow anybody to touch the child from any other angle other than the brain science, what he calls biological approach. So I think this approach of psychiatry, I think, is the future of psychiatry, and he will take us long way and to the new frontiers of the psychiatry to understand us, not only psychiatry, pharmacotherapy, and to have the courage enough to give appropriate, adequate doses. I think I learned from him few drugs which I never used in my life, and they were melatonin. Then I used to give a lot of propranolol, which I had now developed a very good need to use in a higher dose because of his suggestion. And I have been using, I was fond of benzodiazepine, which was condemned by many psychiatrists, but still I am fond of it, but I use now it more frequently than before. So these are few things which I have learned from it. And I always look forward for him for any guidance, any suggestion. And I am almost always in constant touch with him, not only for my own problems, which I have been experimenting on myself. I am taking melatonin and donepezil since last 11 months. He's treating my grandson for autism. So I am taking his help, and he has been very much useful guide and a colleague, of course, a junior to me, but I think as far as knowledge and other things are concerned, except in experience, he is ahead of me. Thank you.
Thank you, Dr. Amrit Badani, for setting up the stage and introducing today's resource person. Today, we have a very interesting topic where Dr. Bhaskar is going to talk about the fine interplay of stress, resilience, and psychopathology. We all have been witness to natural disasters. A lot more can be technological. We have seen the pandemic. A lot of things can be terror and also political in nature. We've seen the definition of resilience evolving all the time. And as the name resilience suggests, it's been dynamic, it's been adaptive and always evolving. And there's various models in which resilience has actually been viewed. Right from the time we talked about developmental models, now we are actually at a stage where it is multi-systemic in approach, and we definitely have evolved to a stage where we are saying this is resilience science. So how one's resilience really matters? How does one at one spectrum have an adaptive response and at the other end have a maladaptive response leading to psychopathology is what is going to be explained today. And who better than Bhaskar, who knows so much of the details that Dr. Amrit Badani talked about, is going to be the best job. And Dr. Bhaskar is going to talk about the fine interplay between stress, resilience, and psychopathology today. Over to Dr. Bhaskar. Thank you.
Don't praise me too much. I feel really uncomfortable. I don't think that jhoot kya. I don't like praise. I don't like it. I don't like it at all. It makes something which I hate. I don't want to be an icon. I am myself. I am the iconoclast. And the biggest disservice you can do to a rebel or iconoclast is to make him icon, him or her icon. So no. Please don't praise me too much. So with this thing, let's first recap what we have talked yesterday. Yesterday, we talked about our brain's various processes through which it controls the homeostasis and how the molecular level, at molecular level, homeostasis is grossly controlled. These are the flowcharts which I made to make people understand it. Now, I lied about one thing, that this is the gross thing and I am not going to go beyond that. That is the lie I have fed you in last seminar, because I never wanted my audience to become anxious that और क्या बोलेगा, अब क्या बोलने वाला है, नहीं. So today we are going to delve deep in the real pathologies of brain and how they evolve from homeostatic disturbances and the process of maintenance of homeostasis, which is known as resilience, the much abused word in psychiatry. So our last
Bhaskar, can you go on full
Yeah.
screen mode, please?
Yes, screen mode नहीं हो रहा है. I am sharing the screen. Am I not sharing?
Slide share mode. It should be full screen.
Your screen is shared, your slides are not full screen.
Yes, I would go to that once
Acha.
I start today's presentation.
Okay.
At present, we are now recapping the previous one. So this was the last slide where I talked about the real psychiatric diseases which are hiding in the brain, and they are the genetic group of diseases which cause homeostatic disturbances and cause stress response system malfunction and ultimately destabilization and destruction of resilience, leading to disease, which is multisystemic in nature and starts from brain. So now today we would go in the detail. So what happens when one or multiple of these subgroups of genetic mutations affect brain? Recording in progress? Yes. So whenever there is disturbances in the stress response system due to presence of these genetic causes, there would be exaggerated stress response of brain and there would be resulting dysfunction symptom. The dysfunction symptoms we can divide or we can actually describe in cognitive dysfunction symptom, about which neither psychiatrists nor neurologists were interested till a few years ago. Emotional dysfunction symptom, which psychiatrists owned for themselves. Motor dysfunction symptom, which neurologists took over. Sensory dysfunction symptoms, which again neurologists took over. Behavioral dysfunction symptom, which psychiatrists took for themselves, and visceral dysfunction symptoms, which each specialty dealing with that viscera is owning up. So brain, any dysfunction of brain is 1, 2, 3, 4, 5, 6. 6 layers of expression, and each of them cannot be differentiated. Let's say brain has been affected by a autoimmune process, then there would be cognitive dysfunction, there would be emotional dysfunction, there would be motor dysfunction, there would be sensory dysfunction, there would be behavioral dysfunction, and there would be visceral dysfunction. We cannot give some to neurology, some to psychiatry, some to cardiology, some to nephrology, some to gastroenterology. But that is what has been happening in today's medical system. And by doing that, we are doing a very huge disservice to brain and psychiatry, because all of these are actually domain of psychiatry or psychiatry neurology combination discipline. Anyway, let's go to the real symptoms. And I can promise you one thing. Once today's lecture is over, you would get a gross framework for understanding how each psychiatric symptom evolves. So let's navigate the turbulent sea of real psychiatric symptoms, also known as the pathophysiological responses of stress response system. We would start with the fast universal responses and then would progress to tricky ones. The fast universal response is always exaggerated or prolonged illness behavior. This is not illness behavior of so-called psychology. This is illness behavior of developmental neuroscience, or you can say developmental biology. Every animal shows a typical illness behavior when it is heart or it is skin. We are talking about that illness behavior. And how that would evolve. Initially, there would be cellular hyperactivity in brain. But here, one or more of the steps that connects this cellular hyperactivity to neural cell activation and division is defective. So, ultimate process of new synapse formation, increase in new cell formation, increase in cerebral functionality would be delayed and slow, and most of the time it would be inadequate. So brain would not be able to handle the homeostatic load in these conditions. And this would start the cascade of dysfunctional manifestation. This dysfunctional symptom will manifest with hyperactivity of the system through which brain controls itself and body. Because when brain is hyperactive, the downstream system would become hyperactive. And those downstream system through which brain controls body would cause all the manifestation in brain as well as in rest of the body. So this would be dysfunction of the formative components of allostasis. Allostasis, the so-called allostasis we described earlier. So it would be autonomic nervous system symptom. It would be neuroendocrine system symptoms. It would be immune and coagulation system symptoms. It would be regulatory nervous system symptoms at cortical level, subcortical level, spinal level, and peripheral nervous system level. So, first, autonomic nervous system symptoms. What can we expect? This is a picture of autonomic nervous system. You can see it controls various brain nuclei to various facial structure to lungs, heart, liver, pancreas, whole GI system, whole genitourinary system, including kidney, and all the various salivary gland as well as other secretory glands body. So what would happen to each of the organs? In lungs, there would be increased respiratory rate. There would be bronchoconstriction and increased mucus production, followed by increase in tidal volume and decrease in vital capacity. So ultimately, there would be hyperventilation, shallow rapid breathing, and there would be mouth breathing, because for rapid conduction of air, nasal or paranasal sinuses are not enough. The person has to go to fast lip breathing to maintain this rapid airflow. So there would be mouth respiration to mouth. This would result in dryness of mouth and dryness of pharynx. In cardiovascular system, there would be increased inotropic response, increased chronotropic response. So cardiac output as well as heart rate both would increase at first. Now, cardiac output increase would lead to two events. One is baroreceptor activation, another one is afterload, increase afterload. Now, increase afterload would cause construction of peripheral resistance arteriole, specifically in the peripheral circulation or limb circulation. So blood would be diverted from limb circulation to central circulation. This would result in decreased skin temperature, cold extremities, as well as this would be resulting in increased central blood, and there would be chances of various baroreceptor reflex activation. Some of them might lead to various kind of neurocardiogenic syncope. Now, in the renal system, the renal blood flow would increase, the GFR would increase, there would be increased filtration resulting in increased urinary bladder urine. Also, there would be increased contraction of Bell's trigon muscle, resulting in increased urination. There would be GI symptoms in form of upper GI stasis, upper GI chances of reverse peristalsis and nausea, upper GI poor digestion, but increase in lower GI motility and diarrhea. So we are getting a person who is showing signs of tachycardia, dryness of mouth, who is showing cold extremities, who is showing increased frequency of urination, who is showing nausea, at times vomiting, indigestion, and diarrhea. Now, brain symptoms would be hypervigilance as well as restlessness. In cognitive area, there would be hypervigilance as well as there would be various forms of decision making errors. In sensory area, there would be hyper acute sensory perceiving, as well as in sensory area, there will be increased perception of all sensory modality. In motor area, there will be restlessness. In behavioral area, there will be irritability, as well as there would be loss of concentration. And in visceral symptom, I have already described. So, along with that, I also forgot to mention the skin symptoms. The sweat glands would be hyperactive, and also there will be hyperproduction of sebum, resulting in oily skin. The excessive sweat production would be limited to all flexor surface, means all body creases. Along with that, in those areas which are situated very close to, yes, someone raised their hand.
I think Bhaskar, we can continue. We're going quite good. We'll take
Yes.
questions in the end.
Okay, okay. Probably we will not be able to take question today. Anyway, today I promise you that you would be overloaded. And there would be ultimately cold and clammy extremities. So now neuroendocrine system dysfunction. At hypothalamic level, at pituitary level, adrenal level, gonadal level, GI endocrine level. At hypothalamic level, all hypothalamic hormones would increase, and the hormones which would increase the hypothalamic releasing hormone or which would inhibit the hypothalamic releasing hormone, their tone would also increase. At pituitary level, all anterior pituitary hormones would increase, as well as the posterior pituitary hormones would also increase, but they are in a sense hypothalamic hormones. At adrenal gland level, sex steroid would increase, and all other medullary hormones would increase. At gonadal level, there would be various disturbance and various changes in feedback. Now, I would be more focused on gonadal level because this would give you an important understanding of a often neglected phenomena that we see in our patient. This is a sample gonadal feedback circuit. It is in male, what I am showing in male, but this almost same thing happens in female. There is pulsatile GNI is released from arcuate and kiss neurons, arcuate nucleus, kiss neurons. There are suprahypothalamic control. At pituitary level, there are multiple facilitating as well as inhibiting feedback loop. In this slide, the activin inhibin follistating circuit is not there, but it is also there. Now, at the level of testes, or in case of female, there is ovary. There are also a lot of feedback loops maintaining. This causes normal sexual function and normal cyclic menstruation in female. Now, these are the hypothalamic neuropeptides which affects this cycle. Amongst these, kisspeptin, we know, you know most of this, so I am not really interested in elaborating those because most of the psychiatrists know orexin, hypocrein, ghrelin, neuropeptide Y and their effect and other things. But I would just say that orexin, ghrelin, neuropeptide Y, MCH, CCK, all of these all of these have their level changes when the brain is undergoing through destabilization of homeostatic control, and so they interfere with normal gonadal circuit action. Now, what I would be more interested in, gonadal inhibitory hormone, that is GNIH, the number 11 one. Kisspeptin is also important, but perhaps that would be overload. So GNIH, actually it's a group of hormone which is situated in the brainstem. They connect to hypothalamic or exogenic neurons, POMC neurons, they are activated by various metabolic condition, as well as they are activated by so-called changes in homeostatic parameters, as well as changes in various ACTH loop, hypothalamic pituitary axis, as well as hypothalamic adrenal axis, and ultimately they causes inhibition of GnRH neuron, and they ultimately change the reproductive behavior. Why I am talking so much about this thing? Because when there is destabilization of homeostatic control, there would be, just a minute, I have to, just 1 minute. Just a minute. Whenever there is destabilization of homeostatic control, there would be disturbances of this cyclic ovulation and cyclic menstrual cycle of women. First, there would be an ovulatory cycle. This anovulatory cycle would cause the unerupted ovum to stay as follicular cyst. So they would have change in their cycle length, anovulatory cycle, and also follicular cysts in both ovary. This would lead to a diagnosis of polycystic ovarian syndrome. But in early stage, when solely brain is responsible, these people would not have muscularization feature. These people would not have any kind of increase in prolactin beyond normal or increase in anti-Mullerian hormone beyond normal. But when this thing progresses and involves other hormonal circuits, mean adrenal cortex circuit, and sex steroid feedback loop is disturbed, as well as the adipocyte feedback loop is disturbed, then the other changes occurs, and ultimately we would get fully formed masculinizing features, as well as increased anti-Mullerian factor, as well as increased prolactin. How long it takes from the only brain involved stage to brain and ovary involved stage, we don't know. But this is one thing we have to remember, that PCOD starts in brain. And this whole process is actually part of it. Now, there would be immune system and coagulation system symptoms. There will be allergic symptoms, there will be hypercoagulability, there will be various other immune systems like localized and systemic autoimmunity. Now there will be regulatory nervous system dysfunction syndrome. I have described cortical symptoms already. In subcortical area, there will be disturbances in fine motor movement. There will be disturbances in motor and emotional planning. There will be disturbances in emotional values, as well as motor value-based judgment system. At spinal level, there would be increase in muscle tone, because the neuromuscular junction would actually be hyperactive. Now, which muscles would be more? Which muscles would be more affected? It would be those muscles which are constantly active in our body. Now, the posture maintaining muscles means the muscles which maintain the bipedal structure of ours, are the most active muscles of our body. So they would go into frequent spasm, and we would have the person would have pain in neck, low backache, and pain and spasm in legs. At peripheral nervous system level, there will be various sensory disturbances like tingling and numbness and other things. So what we call these symptoms together in this patient? Anxiety and depression, and various forms depending on what symptoms predominate. So you see, anxiety and depression are universal fast dysfunction syndrome of brain's homeostatic disturbance. They are the first one. They are the universal one. Anything and everything that affects brain and reduces brain functionality would cause appearance of anxiety and depression symptom. And along with phobia, depending on what and which causes hypervigilance trigger in these people. I hope I have given you far idea of the fast, easily configurable thing, because this is easy. This is the easy one. Now we would go into the difficult part. So the fast difficult part, the lifelong genetic trait, which is there when there is genetic defect of any or many of these pathway, which cause this periodic anxiety and depression symptom. How it would present? There would be hypervigilance, constant hypervigilance. There would be excessive rumination. There would be periodic anhedonia. There would be tendency to stick to fixed routine and rituals to avoid sudden changes, because any sudden change would not be able to be processed by brain and would cause information overload to brain. So brain would always avoid to go into those sudden changes. And these people would be stickler to routine. They would always maintain various rules. They would not break any rules. They would not take any chance. They would not do anything rash. They would be highly perfectionist to avoid sudden destabilization and acute stress. The so-called obsessive compulsive personality is actually the prototype. Obsessive compulsive personality trait is actually also the most common trait associated with all psychiatric and neurological diseases. Neurological diseases or so-called diseases, because now we can understand none of these are diseases, these are just symptoms. If you see Parkinsonian personality trait, you would find out that Parkinsonian personality trait is nothing but obsessive compulsive personality trait. If you see neurodegenerative personality trait, Parkinsonian personality trait is actually a very hotly researched topic in neurology. If you go into the neurology journal, the journal named Neurology, you would find talk about Parkinsonian personality trait in every alternate edition. Anyway, there would also be neurodegenerative personality trait. There would also be various kind of psychiatric personality trait, depressive personality trait. All of these are various spectrum of the same obsessive compulsive personality trait. And when they start increasing gradually, they become our obsessive compulsive symptom or OCD, whatever way you call it. And that is why you need to give the final response dose as long as you can give, because in so-called depression or so-called anxiety, we are treating a patient who has acute destabilization, but their background system is capable of restoring back to where it was before the sudden destabilization. It was destabilized, but in a chronic destabilization. When we are treating OCD, we are managing a deteriorating system, a system which is destabilizing completely. And so the drug dose would always be high, and we should always maintain that drug level which caused a patient to go into remission. This is another long-standing question that has came to many exams, but there was no actual biological explanation for it. This stress, resilience, stress response system, and homeostatic balance, if we think clearly, would give answer to these two. Now the other brain condition, and actually now we are going into proverbial Bermuda Triangle of psychiatry, because we are talking about major psychosis. Yes, I am deeply against this schizophrenia, bipolar, and these things, because they are just dogmatic stand by American Psychiatric Association and WHO, because DSM and ICD are nothing but some dogmatic rule system. As I told you, this is again those charts where I promised that I would not go into it, but we would go into it. So I told that whenever there is increased homeostatic load and high information resulting in high information mechanic load, there would be hyperactivity of brain areas handling the load. There would be increased mitochondrial oxidative phosphorylation. There would be increased rate of stress and cellular stress, resulting in cellular stress sensing by NLR and resultant DMP pathway activation. There would also be cellular protein recycling, high number of cellular recycling, and ER stress. This would be the pathological form of that. This is a cell where it is activated by DMP pathway, damage-associated molecular pathway, or pathogen-associated molecular pathway, mitochondrial DNA oxidative state, oxidated lipid, various reactive oxygen species, uric acid, ATP, a lot of things, cytokines, chemokines, they would actually activate this cell, and there would be formation of node-like receptor 3 inflammation. This inflammation would actually amplify this excitation. There would be actually formation of various chemokine. There would also be various transcriptomic changes in the nucleus and would produce various cytokines or chemokines, resulting in amplification of inflammation. There would also be mitochondrial disturbances, which would be triggered by and which would trigger various glutamate pathway disturbances and ATP hydrolysis and other things. Ultimately, it would cause activation of resting microglia, and this would cause cellular death, overactive microglia, T-cell mediated various immune amplification, T-regulatory system would be impaired, the resting state microglia would not be there much, and the M2, this blue is M2 form, red is M1 form. M1 form of microglia would predominate. And ultimately, there would be a multi-step amplification of the whole thing. It would happen when there is hyperactivation of brain cells and the brain cells are causing uncoordinated immune activation, which would not be suppressed by the immunosuppressive part of immune system. So there is immune amplification, which would go in a snowstorm, avalanche manner, and there would be tremendous magnification, which would result in excitotoxicity of cell. And as I talked about neurovascular coupling, there would be destruction of neurovascular coupling too. The astrocyte end plate would cause pericyte to get more active. There would be loosening of these tight junctions, and these various factors would be secreted inside the cells, inside from the astrocyte end feet to pericyte and through pericyte to blood vessel. This would result in huge propagation of vasoactive peptide, along with there would be activation of microglia, activation of presynaptic neuron, and this depolarization. And ultimately, this neurovascular coupling would result in a widespread spreading vascular dilatation, number one. Number two, neural tail stimulation followed by cortical depression, and along with that, chronic excitotoxicity. This would result in pain in the trigeminal system, and we would call that headache as migraine headache. So this is how migraines originate. Now, glial cell can be activated by all of these things. I am not going into details. I know I have started confusing you. So whenever there is microglial activation, this microglial activation would cause damage to various key neuronal substrate. There would be disturbances in synapses. The synaptic number would go low. There would be various forms of dendritic pruning. There would be imperfect myelination. There would be migration disturbances of the cells, and they would come into a deranged connection. So we would get first a picture of a person who is doing things repeatedly because of that underlying obsessive compulsive trait. Now, these people, amongst those obsessive compulsive traits, some people would have impaired immune activation trait, and they would go into hyperimmune activation followed by cortical spreading inflammation, vascular vasodilation, and ultimately cortical spreading depression, resulting in migraine. Some of them would go further, and their brain would start showing various disconnection syndrome, various excitotoxicity, resulting in chronic anxiety, chronic low mood, as well as periodic hyperactivation and periodic excitability. We would call this as activation state as mania, and the low stage as depression. And we would create a picture of bipolar disorder. Now, this again, those active state or those in hyperinflammatory state initially would not result in much cellular loss, but as it progresses, there would be various forms of neuronal destruction. There would be changes in early stage, means developing CNS. There will be changes in later stage and ultimately adult stage or ages. Each of these would cause successive dysfunction of microglia and impaired microglial function, followed by successive disturbed immune activation, disturb cellular connection, and would result in a group of people who would have this obsessive compulsive feature, these periodic anxiety and depression feature, along with periodic brain activation, and also a chronic cognitive deficit, chronic deficit in various functional areas. We tend to call these people as schizophrenic. So this is chronic psychosis. This is the picture. We see microglia, how microglia disturbances, how glial progenitor cell disturbances, how chronic immune disturbances are causing all those. So this is where I end today, and I ask you people whether you have understood or not, or have I made you too bored and too tired. Hello.
You want to end the presentation here? और साइकोट्रॉपिक्स भी थोड़ा बताओगे?
साइकोट्रॉपिक मैं बताऊंगा, लेकिन पहले मैं थोड़ा ये पूछ लूं कि कुछ ज्यादा तो नहीं हो गया?
Okay, so we'll invite a few questions. Any clarifications till now?
Then we would proceed again. लोग भाग रहे हैं, मैंने ज्यादा बोल दिया.
Any queries? Yeah.
हाँ, तरुणदीप, सुस्मिता दोनों ने ही क्वेरी किया. तो फिर
Susmita, I have unmuted. Susmita, please unmute. Yeah.
Yes. Sir, I was wondering why brain is reacting like that way. Suppose when I have some blood loss or my body is in shock. So the major organ of the body like kidney, brain, then liver. So who needs extra blood supply? There will be splanchnic vasoconstriction, and this thing will happen, and they will work in a way that like adaptive response. But why brain is reacting like that? If there is anything is there, brain is troubling itself, and along with that it's troubling all other organ, and why it is giving pain to it also,
because hello
and also
hello.
to the whole body. Why brain is working like that?
Because brain is the master organ of body. So whenever there is a change in parameter of body, brain has to readjust the whole body. Brain cannot leave any change alone. So whenever there is blood loss, the diversion of blood from various capacitance vessels, means large veins, splanchnic circulation to other parts of body, would be decided by brain and autonomic nervous system. After that, if the problem persists or that diversion would not create a new homeostatic balance, then brain would start going in a snowballing manner. First, the homeostatic balance to restore, I am giving the blood loss, only the blood loss, okay? The blood, a person has lost a lot of blood and the brain is adjusting to that. First, it would divert blood from splanchnic blood vessel to systemic circulation. It would divert blood from venous capacitance vessel to central circulation. If that makes it okay, well enough, if that doesn't make it okay, then brain would try to reduce the afterload so that heart doesn't go into problem.
Okay. Tarundeep and then
No, I am not complete. Just let me complete. So the brain would start to, actually I'm getting distracted by a lot of questions, so that's why I at times
Don't look at the chat box here.
yeah. So what would happen is brain would try to dilate the afterload resistance vessels so that body doesn't get starved of oxygen and heart doesn't feel too much pressure. But from here the downhill course would start, because by dilating the resistance vessel, brain is actually reducing the total blood flow. So there would be peripheral hypoxia followed by peripheral vascular damage and vascular leakage. Ultimately, there would be formation of a damage associated molecular pathway associated systemic shock syndrome, and ultimately multi-organ dysfunction, and patient will die if brain cannot control. So you see, blood loss trigger it, but if the trigger cannot be balanced, brain would try again and again in various way, and ultimately those balancing act many times kill the patient. For example, in COVID doesn't kill, never kills one. It is brain and it is inappropriate immune activation which kills the patient. Okay, now Tarundev, your question.
Sir, I have
yes.
another question.
Yes,
So,
yes,
sir, I feel like brain is the master organ, but not smarter, not that kind of smarter.
Brain is not smart. But how can brain be smart? Brain is a biological organ. It has to obey the biological process. Brain cannot give up when it knows that it cannot control. Brain has to try. Brain has to try repeatedly. It is all a feedback loop. When one feedback loop falls, another feedback loop comes into operation, and it goes on till a new homeostatic balance is reached. As long as the balance is not reached, brain would go on trying, and ultimately that try would kill a person.
Sir, another question. Sir, initially you described that in 6 domains there may be symptoms. Some sensory system, these things are there. And some domains we psychiatrists are taking care of, some domain are taken care by neurologists, some by all other specialties. So, sir, how it like other domain, how they will come to decide that that is due to the brain thing? Because how can we predict a person that he is showing this symptoms because of that? Like
Yes,
that
yes.
is sir.
Actually, I'm giving you an example. Gastroenterologists have started a stream known as neurogastroenterology because they have found out that there is no local GI pathology in a lot of patients of gastroenterology, and they have diverted those patients into neurogastroenterology. Neurogastroenterology is nothing but brain interfering with GI system. Now, cardiologist has created a stream known as behavioral cardiology. It includes all the patients of cardiac symptom where no local cardiac defect has been found, or there has been local cardiac defect, but that is not able to explain the system-wise disturbances that is faced by all the patients. Similarly, the people are talking about behavioral nephrology. People are talking about behavioral pulmonology. So each of these streams are finding their brain patients and they are segregating them into their own subgroup. So yes, that can be found.
So our subject is being taken up by other subjects. So like we should be the specialist in this thing, na? Like see, sir, if a person
Smita, if we talk about these things, then
I think we should let other people also talk, Sushmita.
Yes. This
Bhavish bhai.
Yeah. Hello. Good evening, sir. Hello, so this is
भवेश
Dr.
भाई, ये कई बुक से नहीं, मैं नहीं रीडिंग पढ़ रहा हूँ. So there is no name of this book. If you want to know what is the name of the book, then wait for at least 5 to 6 years. Let me write it.
5 to 6.
Yes.
Okay. So you
Sir,
have.
can I ask the question? Sorry. Hello.
Yes, Tarundeep.
Hello, sir. Good evening.
Yes.
Thank you for presenting, sir. Very insightful and as usual. So, sir, I want to ask 4 things which I'll ask together. First thing is that can we also explain glucose intolerance or hypertension this way? That's number 1.
Yes.
And
No. Let me answer you one by one. Yes. Glucose intolerance or impaired, the right word is impaired glucose tolerance. IGT is part brain, part adipose tissue, part various other endocrine organ. So yes, IGT can be explained this way. So is hypertension. So is in fact frank diabetes. Frank diabetes and its complication are many times and many areas determined by brain.
so sir, does that imply, talking a bit more with a like contrarian view, that does that mean that high dose SSRI can treat PCOD or glucose intolerance?
This is something that would be very interesting to try. Let me give you my personal experience, because this is one thing that you would not find in any research manual or any research paper or anything. Only various practitioners, if they open up, they would be able to give you their experience. I am sharing my experience. In my practice, I see roughly 1,500 to 1,700 patients per month. Now, amongst these patients, I have seen a substantial group of patients who had previous diabetes, previous hypertension, have had to reduce their anti-diabetic drug or antihypertensive drug after getting adequate dose treatment from me. This is one evidence I have. In case of PCOD, my experience is not so clear. In PCOD, I have seen that their endocrine profile gets slightly better. They perform slightly better. Their rates of menstrual disturbances slightly better. But the problem is there is no reversal, like either hypertension or diabetes. So this is my accumulated data from my practice. I would say, as I always say, single person observation doesn't hold much value. We need other people to step in and share their experience, and if possible, form a collaborative group publication. Only then we can say this with confidence. Till then, it is just a single practitioner's experience, which some other practitioners shared, but there is no research publication on this.
Okay.
Now, say to your third question.
Yeah, sir, just to contradict your view and your hypothesis, I'm sorry, but please just listen, that
why not?
If we go through,
challenge me, I would be happy.
Sir, if we are going through the homeostatic model as per your study and research, then
no, not
the
only
homeostasis
up to homeostasis is not my study or research.
No,
The explanation is mine, but
yeah. So,
the everything else is there.
sure. So, sir, what I'm trying to say is that if, let's say that a poor homeostasis is leading to a consortium of symptoms, then perhaps a person should have more resilience or a better homeostasis management when the person is young or in a better body. But then why do all of these symptoms or illnesses or whatever you may like to call, they emerge more in young adulthood and not in the middle age or in the late age? Also, when we give side effects, also,
No. Let me end here, because this is third question. Let me answer the third question, then we'll come to fourth. Okay. So your question is why if homeostatic function is the cause, then why patients are coming into young age? Because according to your understanding, homeostasis is better functioning in young age. Not really, not at all. It is a genetic process. Homeostatic maintenance or stress response, whatever name you call it, it is a genetic response with epigenetic modification. Now, genetic response would depend on collective genetic load on that genetic system. Collective genetic load means how much dysfunctional genes are there and how much protective genes are there. That total balance is known as genetic load. Now, in those persons who have high genetic load, then they would have an earlier chance of dysfunction. This is number one. That is why in those patients who present early, they have higher genetic load, higher genetic burden. Number two, and more interestingly, is our body has circadian clock, seasonal clock, and number three, life cycle clock. Now, life cycle clock is very interesting. It's a molecular mechanism which determines which set of genes would be expressed more for protein synthesis during which stage of life. Some genes are active during childhood, some are during adult stage, some are during old stage. Now there are two bridge periods. One is when childhood is actually getting transferred to adulthood, the adolescent age. And the second one is when adulthood is transferred into old age, the middle age. These two periods are heavily gene change time. In this time, a lot of genes of our body changes their function. Some would become defunct, some would become more functional, some would become less functional, and things like that. If you notice, all non-communicable diseases increase in adolescence and in middle age. Let's say cancer, bimodal peak. In Hodgkin's disease, it is purely known as bimodal peak. In others, the bimodal peak is not always discussed, but it is always there. In diabetes, bimodal peak. In hypertension, bimodal peak. In all psychiatric symptoms, it is bimodal peak. So your point is not actually contradicting homeostasis or contradicting stress response. Your point is just due to not understanding of the whole genetic regulation of body processes. Now your fourth question.
Thank you, sir. I'm sorry, I'm mindful of others' interest also, but I'll quickly ask it. That so according to this point that you raised, that all obsessive compulsive personality traits actually end up as Parkinsonian traits. So, but
not all. No, all.
Okay.
Obsessive compulsive personality trait is a pan phenomena. Pan phenomena means any kind of non-communicable disease present from birth with obsessive compulsive personality trait. The brain is, for example, let's say we get a person who is destined to develop multiple malignancies in their future life. They would have obsessive compulsive personality trait along with something else, depending on their specific gene formation. All persons who are destined to develop neurodegenerative disease, be it Parkinsonism, be it dementia, would have obsessive compulsive personality trait along with something else which is characteristics towards their own specific genetic defect. All non-communicable disease person would have obsessive compulsive trait. So it is not purely Parkinsonian personality, but neurologists love to describe this as Parkinsonian personality. If you search in net by the name of Parkinsonian personality, you would come up with lots of papers. So I gave name of the Parkinsonian personality a special mention, but it is neither meant that all obsessive compulsive personality trait would end up in Parkinsonism, or all Parkinsonian personality patients are only OCPD.
Okay. So sir, my question here was actually, I didn't complete it. So OC spectrum is also related to autism spectrum and eating disorders and OCD. So is all of that also a part of this spectrum itself? And that was the fourth question. And the fifth question,
I actually missed your fourth question because Alima has actually sent a message. What would be your fourth question? Please again remind me.
Sir, so the question was that you mentioned that OC traits can also present as Parkinson's. So my question was that OC trait is also overlapping also with autism spectrum and other conditions.
Everything.
So
everything. Autism spectrum. Autism is not a disease. It's again a symptom. Okay. So yes, it would always overlap with autism spectrum. In fact, a autism spectrum symptom, if we see in a developmental way, child developmental way, autism spectrum symptom are forerunners of OC symptom. But again, that would go. That would make us go into child psychiatry, and people would be just मेरे नाम का सुपारी दे देंगे चाइल्ड साइकियाट्रिस्ट लोग, अभी नहीं जाना है. So BMT has raised his hand. Please unmute yourself. Please unmute and ask.
Hello.
Yes.
Yeah, my question is, if a person who has been suffering from anxiety or depression, and after a period of lifetime of some experience, he improves, is it because of genetic factors alone, or environment also plays a role?
Environment means here there is actually what would happen. Let's say some person has a genetic defect which would result in his or her brain not functioning optimally, and this person would develop anxiety and the depression symptom. But as the person's life progresses, this person having a good genetic basis of learning and having a good understanding of various environmental triggers are able to avoid the environmental trigger, are able to learn which things triggered them and which things are actually beneficial for them, then there is a chance that due to these two combined factors, their chances of getting triggered would be less and their symptomatology would become more stable. So here, the learning genetics and some environmental factors do play a role. Genetics is vulnerability genetics, genetics is resilience genetics, genetics is also learning genetics. Here, their learning genetics as well as their environmental input has made a difference in their life.
Bhaskar, I think we should hurriedly go through the psychotropics and then.
No, I am not planning to go into psychotropic actually. I was waiting for the response.
Can I ask one last question? Can I ask one last question?
No last question. I know a lot of people are itching to ask questions. So I would ask everyone, clear your doubts. Anyone who wants.
Lim, you first, clear your doubts.
What are the other traits other than the OC traits?
There would be compulsive impulsive trait, which I always talk about. Compulsive impulsive trait is just a bifurcation of obsessive compulsive trait. What happens is these persons have hyper vigilance, these persons have ruminating tendency, but their prefrontal control or frontal control or neocortical control, whatever we call, is not well developed. So they frequently misjudge, they act on various impulses, and their motivational control is not at all great. So they would develop obsessive trait, compulsive trait, along with impulsive trait, along with various aggressive trait, and we would classify some of them into addictive personality, some of them into so-called antisocial personality, some of them would go into borderline personality, provided their pain and pleasure areas are sufficiently closely linked, and along with them, we would also term them histrionic and other things. These are yes.
Kshitij asked, Kshitij Srivastava, that these OC traits, they could also be a source of strength in high achievers.
Yes,
so take on
exactly. I am talking about traits. Traits are neither good nor bad. Compulsive impulsive trait. If a manager, if a salesperson gets this compulsive impulsive trait, the salesperson would be able to sell fridge to Eskimo. They would be such a smooth talker and such a accomplished manipulator. Now, similarly, these obsessive trait, they would help the person to go to peak of their professional life, because these people would be dependable, these people would have traits which make them perfectly suited for any responsible job. So traits are traits. They are just like height, weight, other thing. So they are there. They give us some vulnerability, some strength. Problem is that the vulnerability that we get is exaggerated normal response to various environmental or external environmental or internal environmental destabilization, and that let these people be labeled as depressive, sometimes anxiety prone, sometimes other thing. This is just a trade-off. Just as I am 6 feet 6 inches tall, that means Indian Railway normal coach is not suited for me. Whenever I go into railway one night journey, half of my leg is out of bunk, and people either actually beat my leg or they get stumbled on my leg. Similarly, I cannot ride in any buses or other public vehicle. But again, due to this height, I am easily noticeable. I can reach higher spaces easily. So just like high height just like low height. These are normative trait, but exaggerated normative trait can give us various advantages and disadvantages.
Bhaskar, what I want to know is, one thing you have talked with OC traits, it is in the classical sense that we have been taught about. So what are the other traits, the other personality traits dimensions hain, are they not important, or are they derivative of this OC only?
They are derivative of OC personality trait and compulsive impulsive personality trait. These two are stable personality traits. Baki sab, they are various combinations of this.
So suppose a dissocial trait.
Dissocial trait is predominantly compulsive impulsive trait along with obsessive trait. Obsessive trait उसका हो ज्यादा भी हो सकता है, कम भी हो सकता है. Compulsive impulsive trait उसका ज्यादा होगा.
Okay.
Narcissistic personality trait. Narcissistic personality trait is some obsessive person in whose life most of the decisions are correct. That person would become insufferably controlling, insufferably arrogant, and insufferable believer of his or her own self-worth. And we would get narcissistic person.
So then schizoid?
Schizoid is those obsessive as well as those obsessive compulsive personality who has very low self-worth, who has very low and rather reduced social exposure, and they are fearful of society, so they avoid social stimulation altogether. Therefore, they are very fearful, and so they prefer to stay in their own self, and we make them a schizoid personality.
So if first hurdle is crossed, we might land up into anxiety and depression, and when it gets more severe, land into major psychosis.
Major psychosis, that might be initially that might be like mania, later that might be psychosis, and they would alternate. This major psychosis idea was very good idea. Their differentiation into schizophrenia and bipolar has created a lot of problems.
And later on, it will land up into cognitive loss-like picture in the late life.
Neuroprogression, and ultimately there is a chance of various neurodegenerative disorder. And we certainly don't know most of the neurodegenerative disorder. हम लोग तो अभी डिमेंशिया बोल रहे हैं, एक्चुअल न्यूरोडिजेनरेटिव डिसऑर्डर के बारे में हम लोगों को पता ही नहीं. There are thousands of neurodegenerative disorders. We are just getting to know them now. For example, in 2021, they have created a new form of dementia, late dementia.
So Bhaskar, what is the practical implication of this knowledge that everything is linked on a spectrum?
अब ये हो जाए ना, so we can, number one, we can finally answer us one of our biggest shortcoming. हम लोगों को लोग क्या बोलते हैं, ये तो सभी में सब कुछ देते हैं. एक साइकोसिस में भी एंटी डिप्रेशन दे दिया, डिप्रेशन में भी एंटी डिप्रेशन दे दिया, एंजाइटी में भी दे दिया, तो फिर इनका स्पेसिफिक ड्रग क्या है बोलते हैं ना. Now, if we understand this thing, we would be able to say no, we are giving it because at its root, it is a common dysfunction of a huge system which is controlling whole body. So our drugs work at specific checkpoints of this system. So each drug can be given in various symptoms depending on what are the presenting symptoms. This is number one knowledge that would give us self-confidence. Number two, we would be finally be able to shake the shackles in the name of antipsychotic, antidepressant, anti-obsessive, and mood stabilizer, because we understand that those doesn't exist. Those terms doesn't exist. Every drug can be used in a phenomena depending on what and how it is formed, and we need not be so dogmatic about using these antipsychotic only in psychosis or antidepressants only in depression. Number 3, and possibly the biggest advantage is, now we can see every non-communicable disease are arising as a seed from these homeostatic disturbances. If that is the true, then our drugs are not only psychotropics. Our drugs are drugs which have immunomodulatory role, which have role in each of these non-communicable diseases in various forms. And so our drugs becomes major drugs, not unnecessary drugs or drugs which are to be stopped in a patient whenever that patient develops some destabilization, which has long been tradition of psychiatry. कोई भी काम हो रहा है हमारे ड्रग बंद कर दो.
So how much help will it give in hypertension or prevention of cancer? Is it a big effect?
Prevention of cancer, there is actually some data. I have sent you the paper before, but I remember the data till now. Roughly 15 to 20% reduction. So, 15 to 20% reduction in solid tissue tumor. This is a two population-based study, means millions of people were recruited, and their conclusion is 15 to 20% reduction in solid tissue tumor. There is no data collected in hematological malignancy or various other malignancy. Number 2, in various inflammatory malignancy, means glioblastoma multiforme or inflammatory carcinoma of breast, there is high percentage of response to various psychotropics. But again, here we don't have any clear percentage noted. In other areas, the data is not so clear. In hypertension, in difficult to, they have created two designations for hypertension. Difficult to treat hypertension, treatment refractory hypertension. Difficult to treat hypertension is where 3-drug combination is needed. Refractory is where 5-drug or more is needed. Now, in these both cases, there are some promising antidepressant trials, but at present, no data. In my personal practice, I and various medicine colleagues have used adequate dose of antidepressants in these people, and some more time than not, we have got response. The number of antihypertensive could be reduced. Well, can it be replicated in other people? That needs to be seen, because single person observation has no value in science. Myself is the easiest person to be deceived by me. So we need replication. Number 3 is diabetes. Now, in diabetes, there is actually study. In diabetes, there are studies emerging where two things are getting clear. Number 1, the newer anti-diabetic drug, they are antidepressants, anti-anxiety, and they have prominent cerebral action. And our drugs do have anti-diabetic action. In diabetes, it is getting some actually concrete base. In other non-communicable diseases, we are yet to find. Post-cancer survival is increased with our drugs, but again, the data is sparse. Interstitial lung disease and various autoimmune diseases of lung, in these cases, antidepressants have worked good. Now, in infectious diseases, there is role of antidepressants. In various chemotherapy regime, there is role of various antipsychotics. But again, these are just tip of iceberg. We need to go long before we can get something. And always we have to remember, whatever I am saying today is so far theoretically tested by many, but practically tested by only me. Unless more people actually try this and find this, we cannot say the last word.
Amrit,
I think we need to call Bhaskar another time, or you want to hear him everything in this session. So
मैंने इसीलिए drugs आज नहीं बोला because the thing is this is such a important area कि drug अगर बोलूंगा तो ये diluted हो जाए.
sorry क्या बोला ना भास्कर, we'll call you another time.
हाँ बाद में बोलेंगे.
I think that will be
बोलेंगे.
Amrit, chairpersons.
Mahesh boss.
I think the last 1 hour plus was such informative, heavily loaded discussion, so much of neurobiology. It's quite hard for somebody who's actually not in tune with the neurobiological discussions to understand. Actually, I found it so difficult to concentrate and keep listening. I will have a lot of doubts, but I think probably this session was for the larger audience, and a lot of people have benefited from the discussion the last 1 hour plus. There are a lot of questions still remaining, a lot of unanswered issues also. But as Amrit was suggesting, I think we're going to have another excellent session by Dr. Bhaskar. I thank Dr. Bhaskar for anchoring the last 1 hour plus, and it was excellent. Thank you, Bhaskar.
Yes, sir.
Badani sir.
Yes, sir.
Hello.
Dr. Badani sir, please speak.
Yes, sir.
I had to strain my head a lot, and my brain is now almost fatigued because of the details Bhaskar has served to us, and I will go through them again through the slides. Okay, I had a question, but I will ask him personally in another forum. Thank you.
Tufan sir.
Thank you, Bhaskar, again for your informative and highly enlightening presentation. As I personally take it, I believe in molecular biological aspect of any science. But for me, it was still, let me admit, it was a little confusing. And there will be a lot of questions to clarify the confusions. I will request Bhaskar for two things. Amrit and Alim coordinate that we have 2 more sessions. And we have got links for these 2 presentations by Bhaskar. We can specifically send the links again, and everyone should go through it and put the note of the questions, which you can send to Dr. Bhaskar, so that he comes prepared with those answers only. Further overloading. And then we can have another session on the clinical implications, because many things came to my mind and many other people over here. That what is its utility unless we utilize has a clinical implication, which at last Dr. Bhaskar clarified that I understand this, I have and made you understand this, I think, but I am only using it. So we must be enlightened enough that we can use it and see its real implication in clinical psychiatry. 2 more sessions, Bhaskar, if it does not disturb you.
Okay, I'm ready.
Thank you.
Thank you. Thank you, everybody. Thanks all.
Thank you.
So I have to give the office.
Now go to Amrit.
Bhaskar, as always, gives you stress as long as he does not log in. Alim and me. Bhaskar आएगा कि नहीं?
Don't ask. Don't.
अरे आज क्या करके आया इसे मालूम है?
Bhaskar will come. He's forgotten. He'll pick his phone. So Bhaskar was 3 minutes or 4 minutes late or 5 minutes late. But then and once he comes, then he takes away all your attention. He takes all questions. He answers all questions. He puts questions. He questions himself. So brilliant boy, brilliant friend. And what Amrit Bodani was speaking, we all, agree to it.
Dr. Bodani, when talking about telephone, told that I have got many questions to ask. I told that is why you need you here.
It was nice seeing you after such a long time, and it was pleasure hearing to you. Thank you all for coming. I would especially congratulate Dr. Alim because you fit in Bhaskar in this platform. That was a tough call. We had a lot of discussion.
And personal congratulations, Darpan. Darpan ko bolna do haath
Thank you, Torrent. Thank you.
Darpan, unmute and tell.
And Darpan is already dressed as a professor. She wants everybody to clap her becoming a professor.
Darpan wanted to tell something. You can unmute.
Till then, good night. You can unmute. You can discuss.
Yeah.
Thank you, Dr. Amrit, for your kind wishes. Thank you, Tufan sir.